Okay, perhaps we should commence. Hopefully everyone's arrived. Well, welcome once again to the Mental Health and Neuroscience Q&A and Masterclass. Thank you very much for being here. My name is Dan Hermans. I'm the program coordinator for the Mental Health and Neuroscience postgraduate program and a professor of youth mental health and neurobiology at the Thompson Institute. And I'll be presenting today alongside my colleague, Dr. Chrissy Driver, who is the course coordinator and a researcher at the Thompson Institute, the course coordinator for the Mental Health and Neuroscience program. And we'll be presenting to you this evening and hopefully addressing a bunch of questions at the end. Just like to start with an acknowledgement of country. I'd like to begin by acknowledging the traditional custodians of the lands and upon which we all gather today. And on behalf of the UniSC team, I pay my respects to their elders past, present, and emerging. And I extend that respect to Aboriginal and Torres Strait Islander peoples participating in this webinar. I would also like to acknowledge those with a lived experience and a living experience of mental ill health. I'm just going to start with some housekeeping. Just the first note is that this webinar will be recorded and will be providing copies to everyone who registered for the session. And speaking of which, it's very well attended in terms of registrations. Around 400 people registered, so we may not get to all of your questions, but we'll try very much to cover a lot in our Q&A session at the end. So I do urge you to type your questions during the webinar in the chat function, and we'll, as I said, get to them at the end. And if we can't get to through all of them, we'll try to pick them up and follow up on them later. We are going to cover things like eligibility for the program. Yeah, if you have any further questions, as I said, in the chat function, and we can also follow up on those as well. So just by way of introduction in terms of the content, Chrissy is going to provide an overview of the programs, some details around the admission requirements and how to apply, and also a nice coverage of all of the course content. And then after that, I'm going to do a masterclass, and I've just realized I didn't correct and update the topic for this particular webinar, but this one's going to be focusing on youth mental health PTSD in youth, not the importance of sleep for mental health and cognition. So apologies for not correcting that slide. If you are interested in that topic, I urge you to have a look at the recording of that webinar, which we can provide to you as well. But before I get into before Chrissy presents and then I get into the masterclass, I just wanted to give everyone a bit of an overview about the Thompson Institute. It's a research center at the University of Sunshine Coast, and we very much adhere to this care model whereby we have clinical advocacy, research, and education aspects to our work. So in terms of clinical, the Institute provides services from psychiatry and psychology, healthy brain aging, brain stimulation, neurofeedback, clinical trials. We're very strong on advocacy from public events and community engagement with industry partnership, lots of online resources, family inclusive practice, lived experience program. Our research themes at the moment, major research programs include youth mental health, suicide prevention, aging and dementia, stress-related disorders, and we're developing other programs in areas such as eating disorders. In terms of platforms, and I'll explain a little bit more about that in the next slide, but these run across research themes or programs, and they include things like neuroimaging facility, data analytics, and molecular biology. And of course, education, which is highly relevant to this webinar. Our big focus is on mental health and neuroscience postgraduate program, which you're going to hear all about tonight. But we also have high degree research students like PhDs and masters, as well as involvement with the clinical master's psychology program run by a discipline of psychology at UniSC and CPD training. I explained this before in terms of the platforms, but our work at the Thompson is very much integrated in the sense that the major research themes, as I mentioned before, youth mental health, suicide prevention, aging dementia, PTSD, and stress-related disorders, eating disorders, they're all informed by these platforms, whereby we look at imaging or clinical trials, molecular biology, clinical services, and as well as how engagement and education programs run across these. It's also very important to note that we've just completed the building, which is the National PTSD Research Centre. So the Institute is certainly expanding, and a big focus for us going forward is going to be PTSD, which of course is an aspect of the or a topic in the masterclass tonight or today. Before we hear from Chrissy about the program, I'm just going to show you this video, some feedback from some of our students in the Mental Health and Neuroscience program. So listen in.
The information that I've learned through this course has been applied into my job many times when it comes to the vulnerable populations, those at risk of mental health and suicide. By studying online, I can still get a postgraduate education while working the job that I love.
As an educator, we certainly are tasked with delivering the curriculum, but we're also tasked with ensuring that the young people are safe and supported.
I'm an advanced care paramedic with Queensland Ambulance Service, and I work as a rural reliever across a lot of regions in Darling Downs. I chose to study neuroscience and mental health at USC because they offered an in-depth background into the neurobiology of mental health to better understand why mental health develops and how to better treat the symptoms and conditions my patients have.
I've obviously got a real vested interest in mental health and neuroscience, having done my background in psychology and then continuing to work with young people each and every day. So I've been able to engage with a lot of the learnings in my current context as a secondary school educator, particularly around mental health and mental illness in adolescence. I work full-time at the moment, so obviously online study was my preferred option. In my classroom teacher role, I teach senior psychology, so I've found that being able to engage with the content in this program has enhanced my practice as a classroom teacher and certainly warrants a lot of interest from my students.
So what I really like about being involved in this program is, first of all, it's one of a kind in Australia. It's the only fully online mental health and neuroscience course. The other aspect I really enjoy is actually getting to see the students, even though it's in an online setting, getting to chat to them and hear about how they're already applying their knowledge in their professions and in their practice.
Studying online means that I don't have to go into uni. I can study from home in my own environment, on my own downtime. Each week we get to have Zoom classes and ask real-time questions and get answers from experts in the field.
The great thing about what the students get to experience in terms of the teaching staff is that we have such a wide range of contributors to the content. So the students get to hear from a variety of experts at the Thompson Institute who are all at the forefront and cutting edge of their research areas. So we have a very multidisciplinary cohort: paramedics, nurses, counsellors, social workers. Everybody's recognising that this is a really important aspect of their work.
As educators, we know that the young people in our care are faced with unprecedented amount of challenges, and having the knowledge and developing this literacy around mental health and neuroscience is invaluable for us educators because it helps us to ensure that the students in our care are well supported.
Studying mental health has been really important for me because as a paramedic I can deliver that frontline care to those in crisis, to be able to help those people who are often misunderstood or stigmatised, to break that barrier and deliver the best possible care that I can.
Great, thanks for getting that video going, Dan, and thanks for introducing me. Yep, so I'm Dr. Chrissy Driver. And thanks, Dan. Yes, I'm Chrissy Driver and I'm the course coordinator of all the mental health and neuroscience courses. So I'm going to talk you through a lot of the information about the courses, the eligibility criteria, and what you can expect from what our online modules will look like. So as you can see in this video, we do have a range of students from different backgrounds and professions, and some other professions that we currently have in our courses are things like all areas of allied health, mental health clinicians, support workers, medical professionals, but we do also have students with backgrounds in other areas of science, things like high performance sport, workplace injury and rehab, diagnostic imaging, youth education, suicide prevention, disability support, Also things like public relations, business consultancy, policy and government, and so much more. So you'll see that, you know, our student cohort really is quite varied, but what they all have in common, and what you guys have in common, I'm sure, because you're here at this webinar, is a passion to help those people that you come across in your professional and personal lives who may be struggling with mental health concerns. So we are seeing a range of professions, but all these people are recognizing that having this mental health and neuroscience literacy is important to enhance their current practice or professions. So whether you're wanting to expand your career horizons or start a career in these emerging fields or go on to higher degree by research, you know, this program is applicable to a wide range of multidisciplinary fields. So I'll just talk you through the different programs that we have on offer. We currently have a graduate certificate, which is the 4 courses. The graduate diploma is the 8 courses. And now we have the master's, which has a research focus. So this is all in mental health and neuroscience. Currently, the graduate certificate and graduate diploma have Commonwealth supported places. So this does dramatically reduce the cost of these courses for you, the students. We do know that postgraduate study is expensive. So the great news for you as students now is that if you want to apply now, you will get those Commonwealth supported places. So these programs are nested. This means if you wanted to start off in the graduate certificate, which is the 4 courses, to get a taste of the content before committing to the grad dip, you can do that. Then you can, excuse me, upgrade to the grad dip, where you just then complete those extra 4 courses to make it a total of 8. Of course, you can go straight into the grad dip as well, which is the full 8 courses. So with the master's now, which has the research focus, this does include a supervised thesis, and this will be using secondary data, conducting data analysis, and manuscript writing, hopefully for publication. So the idea for this master's is to give you that alternative pathway to HDR if it's something that you're interested in, high degree by research. But please do note that the eligibility criteria is slightly different from the master's to the grad cert and grad dip, and I'll go over that shortly. So the graduate certificate is currently offered part-time. We have 2 courses per semester, but the grad dip is able to be completed full-time, as we have all 4 of those courses on offer each semester. But of course, you can choose to do that part-time as well. You can, for both the grad cert and grad dip, you can choose which courses you start with. There's no particular designated order, and you can start in semester 1 or semester 2. The master's is slightly different in that you do have to complete all 8 of the graduate diploma courses first before you can then continue on to complete those master's courses. So I'll go through some of the content you can expect in these courses a little bit later, and you're also going to get a taster module via email after this webinar, so you can see exactly what our modules look like. Okay, so if we talk about eligibility criteria, so next slide, thanks, Dan. So in terms of eligibility, you may actually be quite surprised with what degrees might be relevant. So obviously an undergraduate degree in health, science or psychology, etc., is helpful in terms of the foundational skills and knowledge, but we do also consider people with degrees in different areas and seemingly unrelated areas. We do have a number of students without these types of degrees who have been successful in these courses. So yeah, we have a broad range of backgrounds from our students. For those who don't have, you know, the straight science or health or psychology background, it might be a steeper learning curve, but it's not impossible. And so we are also interested in finding out if you have any mental health vocational and work experience, and also why you might want to do this course. So you might be thinking, what do I do if I don't have a science background? Well, obviously, you know, the health, the psychology, and the medical sciences are helpful because the content is ultimately neuroscience orientated, but we do provide a lot of scaffolding to build that basic brain knowledge early on in the courses. And then the neuroscience components are really focused on being applied into the mental health context. So we're not expecting you to come away knowing everything about the brain. And in fact, Dan and I will be the first to tell you that we still learn new things about the brain all the time. You know, neuroscience is a massively growing area of research and knowledge at the moment, which is super exciting. And so therefore, it's a great time to be involved in a course like this. So, you know, most students do find the neuroscience tricky to start off with because it is like a whole new language. But trust us when we say it will become more normal as you progress through the courses. You will start to notice themes across the content, especially in terms of, relevant brain regions and networks that might keep, that will keep popping up across different disorders. Anyway, back to the career pathways. So in terms of career pathways, what I can say is that our current students are actually giving us examples of how they're using these qualifications to benefit their current careers. For example, as you've seen in the video, assistant principal was featured. We saw him teaching his senior psychology, but also drawing on the course content to be more across the neuro aspects of that psychology teaching, and to enhance his understanding of the current mental health issues that are facing youth every day in his school, and using this in order to better support his students, but also the teachers that he's working with. For others, it's about becoming more specialised in their current mental health or health practice, having more in-depth mental health and neuroscience knowledge. Our students have told us that this helps them in having a better understanding of their clients' needs, especially from a more holistic and whole person perspective. Others are using their qualifications to enhance their CVs when applying for more senior positions or advancing their career prospects, or even moving into more mental health and wellbeing based roles within their organisations. And employers are seeing that they have the skills and training in this area that can be applied to their current profession. Obviously, there's the personal and professional application of knowledge, but there's also that increased confidence in our graduates that comes with that mental health and neuroscience literacy. And because so many organisations now value that health and wellbeing perspective, having employees with this knowledge is preparing them for the future in terms of the skills needed in the workforce. So that's a bit about what our students have told us so far. Obviously, it's also a pathway to high degree by research and those emerging research areas. So next slide, thanks, Dan. So I'm going to go through these all in a little bit more detail. So actually we can jump onto the one after that. Thanks, Dan. So in terms of the course structure, we are fully online and self-paced, but we do sit within UniSC's usual semester dates, meaning that we offer the equivalent of 13 weeks of content. But as it's fully online, the course is, as I said, a self-paced in that you can choose when you do your study. So the only deadlines you have are the assessments, but essentially you can pick and choose when you do your study and how between that sort of 13-week semester timeframe. So for those of you who like a bit more structure, you do hear regularly from me, your course coordinator, and you can choose to follow along week by week if you like. The university does recommend about 10 to 12 hours per week per course as a rough guide in terms of how much work you would put in. And this roughly entails 3 to 4 hours of taught content. So this usually includes, your core concepts, your readings and things like that. The rest is self-study and obviously working towards and on your assessments. So with our online courses, you can obviously structure this in a way that suits your work and life commitments. And our modules are designed generally to take a couple of hours to complete, but longer if you choose to engage in all of the post-module activities. And these are really designed to help you consolidate your learning and also help you to start preparing for your assessment items. So that can be a useful way to approach the course. Any additional time on top of that is obviously your further self-study and assessment work. So I'll just briefly talk about some of our assessments because a lot of people want to know how we assess our students. So generally we focus on interpretation of the most recent research for a specific topic, and then we're looking at those critical evaluation and synthesis skills to form balanced arguments that are related to the content and the specific evidence base that we're teaching about. But we do also really encourage the skills of science communication through our assessments. So we do have various styles of writing and presenting, rather than just testing knowledge through things like multiple choice exams or standard essay writing. So we are trying to send our graduates away with the skills to communicate and apply your knowledge in a variety of settings, rather than just remembering content. We also understand that most of our students work part-time or full-time. So many of our students do choose to study part-time, which can be 1 or 2 courses per semester. Now, the feedback tends to be that this is a better way to pace the learning, and it allows our students to focus on the content in more depth, especially when there's those tricky neuroscience concepts that you might be learning about for the first time. But it also provides opportunity to apply new knowledge into their current practice straight away. And obviously, this ultimately encourages lifelong learning, which is what we want. But we do also have students who do manage the full-time load, so it's really up to you to think about how much time you think you can allocate to study over the period of the semester. As you heard in the video, the content is developed by a huge range of researchers, clinicians, and educators who are at the forefront of their areas, so you don't hear from the same lecturer for every topic. This wide variety of contributors really enables us to deliver the most current and evidence-based content. And this also gives us the opportunity to provide that really unique blend of applied mental health and neuroscience content coming directly from the experts who are working and researching in this space. So just to clarify, these courses are not mental health with a little sprinkling of neuroscience. They are very much a balanced blend. So you will be learning a lot about neuroimaging and how we apply neuroscience knowledge to mental health research and practice. As you'll hear from Dan later in the masterclass, understanding the brain is really crucial to helping us better understand mental health in general and how we can maximize diagnosis and treatment of mental disorders. So this unique blend really does make our program different to other mental health programs that you may see advertised, and currently this is the only one of its kind that is fully online in Australia. So next slide, thanks, Dan. So as I said, we do have 13 weeks of taught content, and each week contains a module, which is broken up into different styles of learning materials. And this enables us to cater for lots of different learning styles. So it is delivered in a very unique multimodal way. So we don't have this traditional sort of 2-hour recorded lecture, set up and then a tutorial-based format. So I'm going to talk you through what you'll typically find in a module of content. So first we'll have some readings, and these are generally from academic journals, which set the scene for the module. You'll notice that none of our courses are textbook based, as we're developing and updating the content regularly based on the latest research. Then you'll get to your core concepts, which are delivered in our engaging multimodal format. So think of this as the type of content that would usually be covered in the 1 to 2 hour lecture. So the real core concepts that we want you to understand for that particular module. But in these multimodal modules, it includes a mix of text, images, graphs, pre-recorded mini lectures, other videos to help explain concepts such as 2-minute neuroscience videos, which are a great resource. We provide links to other resources like conversation articles, and there are also interactive activities embedded into the modules to enable you to kind of check your own understanding of the content as you move through the module. After that core concepts part, there's a range of interactive activities, which are things like questions and reflections that we provide to help you consolidate your learning, but also to build towards your assessment items. So these type of activities make up the types of things that you would do in an in-class tutorial or workshop. But you can do this asynchronously. So these activities are self-paced, and you can choose when you do them, but also you can choose how much you actually interact with your peers and me online via these discussion boards and comments on videos. So we also do have regular Zoom drop-ins, as you saw in the video. That provides an opportunity to meet your peers, to collaborate, to discuss the concepts, and also ask many, many questions about the assessments. So while these courses are fully online, you will hear from me regularly, and you'll have multiple opportunities to connect with me and your peers. But at the same time, if you are a more autonomous learner, there's really no obligation to engage in any of the interactive Zoom-based activities, as the content is provided in a way that ensures that all learners are given the opportunity to access all the information necessary to succeed in the course. So the next slide is a great image that just kind of gives an overview of all the courses that we have in the graduate diploma and some of the individual modules that we cover. But I'm just going to briefly talk you through those 8 courses now, and then I will be handing over to Dan. So next slide, Dan. So these are the 4 courses that make up the graduate certificate and also half of the graduate diploma. So in MHN 701, which is Mental Health and Neuroscience Translational Research, we learn about how across the lifespan, mental disorders do differ in their onset, type, and complexity. Now, we know that current diagnostic approaches and treatments remain limited and in some aspects are actually lacking. So in this course, we do focus on translational research to better understand mental disorders and optimal treatments, and how the latest scientific research findings are actually put into practice. We also explore novel approaches to diagnosis and treatments, such as transcranial magnetic stimulation, ketamine, and neurofeedback. In our youth mental health and neurobiology course, we really unpack how adolescence is a dynamic period of significant physical, cognitive, and social development, and also emotional maturation. So we learn that it's a difficult period as the brain undergoes several structural and functional changes. And we also know that half of mental health conditions emerge by the age of 14 years of age. So there is a huge need for understanding adolescent neurobiology. So we do investigate the neurobiology of the most common disorders that emerge in adolescence, and focus on other key factors that also affect the mental health of adolescents, including things like social connectedness, cyberbullying, and sleep-wake patterns. So you'll hear about some of the fundamental information about adolescent neurobiology and the effects of trauma on the brain from Dan very, very soon in this masterclass. So next we have a whole course devoted to neuroimaging mental health, which is probably the most technical course. But as I said, you're not expected to learn all the intricacies of brain imaging. We do learn how MRI has allowed researchers to understand how the brain is wired in health and disease, and we look at the latest imaging technologies used, particularly obviously in mental health and neuroscience research, but we do have a focus on MRI. But we also learn about transcranial magnetic stimulation, magnetic resonance spectroscopy, other techniques using EEG, and how these things are actually being used in AI and machine learning to help us understand and how to predict these types of things. We also investigate neuroimaging biomarkers in mental health and risk profiling. We look at diagnosis and treatment, and basically how neuroimaging supports the pursuit of new knowledge, particularly in the mental health context. The last course of the grad cert is we have a whole course on understanding and preventing suicide. So we know that suicide is a significant and complex public health problem, and for some age ranges, it's the leading cause of death. We also know that its impacts on communities are far-reaching. So we do cover the major theories of suicide, the current evidence base around its neurobiology, the innovations in assessment, prevention, but also how this translates to things like policy changes. We do explore person-centered practices, at-risk and vulnerable populations, and also the role of the community in suicide prevention. So looking now to our final courses that make up the grad dip. So our Healthy Brain Aging course covers the spectrum of declining cognitive function. So from normal brain aging at one end to diseases such as mild cognitive impairment and dementia at the severe end. So whilst healthy brain aging is accompanied by changes that impact cognition and behaviour, dementia is a major cause of disability among older people, with 10 million new cases per year worldwide. So in this course, we'll address the neurobiological changes in diseases like dementia. However, lifestyle factors, which we'll talk about in a moment, can protect against dementia by up to risk, by up to about 50%. So in this course, we do learn how lifestyle interventions can actually prevent the onset and progression of brain aging and cognitive decline. In our course on neurocognition and mental health, we learn how different neurocognitive factors are specifically linked to underlying brain regions, networks, and processes. And then we explore how neurocognition has actually been utilized to better understand the functional impacts of various mental illnesses. So a range of cognitive functions such as attention, memory, decision-making, affective regulation, metacognition, and social cognition all play key roles in current mental health research. So we really unpack how these measures provide insights into the underlying neurobiology of different mental disorders. Of interest, particularly for the webinar this evening, we have our stress-related disorders course. Now, this uncovers how, generally stress promotes vulnerability to or exacerbates symptoms of most mental illnesses. We know that stress-related disorders result from an atypical response to anxiety due to physical, mental, or emotional stress, and that post-traumatic stress disorder can develop if these feelings of fear, anger, and depressed mood persist after exposure to, a really traumatic event. So in this course, we learn how, these atypical responses to trauma lead to disorders, and how this changes the brain and how this manifests into, debilitating symptoms. We do discuss a lot how a lot of the current treatments are not effective for PTSD. So we do explore the emerging evidence behind some of the novel therapies in this space. Finally, our lifestyle factors course. This covers how things like nutrition, physical activity, sleep, substance use, stress management, social networks, and the environment are all lifestyle factors that actually shape and impact our mental health and well-being. So in this course, we do learn about the emerging evidence base in lifestyle medicine and explore ways that this approach can actually be adopted as an early intervention strategy, as well as how it can supplement other therapies in the treatment of more severe mental disorders. So that's a very quick overview of the 8 courses that we cover in the grad dip, and obviously the first 8 courses for the masters. Now, lucky for you all, after this webinar, you will get to have a taster version of one of our modules, where we're going to give you a little snippet from each of the 8 courses. And this will also give you an idea of what our multimodal modules look like that I've sort of talked about. So I think that's enough from me for now. I'll pass you back over to Professor Dan, who's going to take you through an amazing masterclass looking at the effects of trauma on the brain. And I hope this gives you an idea of why the courses we have developed are absolutely a combination of mental health and neuroscience, not just mental health. So take it away, Dan.
Thanks very much, Chrissy. Apologies again for not updating that earlier slide describing the topic and theme for tonight's masterclass, but I'll take the opportunity to say that this is the 3rd webinar and masterclass that we've delivered in the last, less than a year. So in July last year, we delivered a masterclass on youth mental health and neurobiology, and then in December, we delivered one on the importance of sleep-wake cycle for cognitive and mental health. So if you're interested in those, I urge you to check them out. They're available on YouTube. So today's masterclass, we are going to be exploring childhood maltreatment and intergenerational trauma, and in particular, their impacts on the neurobiology of PTSD in youth. And the content here is from 2 of our modules in the stress-related disorders course that Chrissy mentioned before. The key symptoms commonly involved in PTSD include anxiety, avoidance, emotional numbness, hypervigilance or hyperarousal, intrusive thoughts, nightmares, and flashbacks. However, these may not be obvious or easy to detect in children and adolescents. And there have been suggestions to describe childhood trauma and ensuing chronic trauma in different ways, including developmental trauma disorder or complex PTSD, which may involve other features such as shame, dissociative symptoms, and interpersonal instability. To set the scene, all MHN modules start with a blurb like this. Most would understand that experiencing adversity and trauma in childhood is highly impactful on the health and well-being of maltreated individuals. However, many may not appreciate just how enduring the consequences may be. The short and longer-term neurobiological impacts of childhood trauma and maltreatment are only recently being better understood. Furthermore, some claim that childhood adversity may explain many of the neurobiological abnormalities that have typically been ascribed to specific mental disorders. So that's often in the way we commence a module, and then we touch on a list of learning outcomes and proceed with the module content. As Chrissy mentioned, we curate content from a wide variety of sources, including articles from the conversation. In this 2021 article, it addresses how common experiences of traumatic events are, particularly in youth, and that as a society, we are getting better at understanding what trauma means. However, there is a lot more required in the public discourse, including having a better understanding of intergenerational trauma. Atkinson also draws on explanations of how stress becomes trauma. When threatening experience exceeds an individual's stress capacity threshold, in the context of perception of powerlessness or lack of agency, a process driven by a lack of conscious control, especially in children. So in this masterclass, I'm going to address two key areas of research in PTSD in youth and focus on the underlying neurobiology in childhood maltreatment and in intergenerational trauma. The link between childhood maltreatment and PTSD is well established. Less understood, however, is the underlying neurobiology, although brain regions impacted by childhood maltreatment have recently been investigated. Intergenerational trauma is particularly relevant to youth with PTSD. And while much has been discovered from studies of war and disaster survivors, there is a lack of research specifically examining the impacts on brain structure and function in youth affected by the trauma experienced by their parents. Hence, my final point, and perhaps one for discussion, is the importance of longitudinal research and how this may be used to help pinpoint early intervention in youth at risk of PTSD and other complications due to childhood maltreatment and/or parental exposure to trauma. Taisha and colleagues reviewed the literature on the effects of childhood maltreatment on brain structure and function. The very first point made in their paper is an important one. Maltreatment-related childhood adversity is the leading preventable risk factor for mental illness and substance abuse. This is because the brain is sculpted by experiences, and youth are particularly vulnerable to the impacts of negative experiences because their brains are undergoing sensitive changes. Childhood maltreatment includes physical, sexual, and emotional abuse, as well as physical and emotional neglect. As many as a quarter of individuals experience some form of childhood maltreatment across the lifespan, and it is associated with a range of problems, including developmental difficulties and mental health problems, with rates of PTSD being particularly high. Individuals exposed to childhood maltreatment are far more likely to have depression, attempt suicide, and develop alcoholism. Significant repeated childhood maltreatment has been found to reduce lifespan by up to 20 years due to epigenetic changes causing chromosome shortening. Importantly, maltreatment-associated brain abnormalities might be understood as experience-dependent adaptive modifications, as they can be observed in clinically resilient individuals. Now, Taisha and Samson suggest that psychopathology may emerge due to the mismatch between the world the brain was modified to survive in and the world it finds itself in during subsequent developmental stages. However, research suggests that those who have experienced childhood maltreatment have distinct clinical, genetic, and neurobiological features. Based on neuroimaging studies of childhood maltreated adults, Taisha et al. Suggests that there are adaptive modifications in the brain's sensory systems, which differ according to the specific type of abuse. Furthermore, they argue that these changes stem from the brain's first filtering of these negative experiences, as depicted in this figure, those exposed to parental verbal abuse show changes in the auditory cortex and connections involved in language processing, whereas those who experience seeing, not just hearing, repeated interparental violence show reductions in visual cortex and compromised connections between regions supporting vision-specific, emotional, and memory processes. Importantly, those exposed to this between 7 and 13 years of age had the most brain changes. Finally, adult women sexually abused before 12 years of age had reduced visual cortex and visual association areas involved in facial recognition, or thinning of somatosensory regions involved in the processing of tactile sensations from the genital area. Teicher and colleagues conclude that these differences can be explained as specific modifications to sensory systems that convey the aversive experience as a means of attenuating the effects of repeated exposures and thus reducing distress. This figure shows the findings of Teicher and colleagues' own study of network architecture in the brains of 142 childhood maltreated young adults compared to 123 unexposed young adults. 3 key brain network differences were revealed. In the first, unexposed controls showed greater centrality in the left anterior cingulate, a brain structure involved in regulating emotions, motivations, and impulse control, whereas maltreated individuals showed markedly decreased centrality in this network. Conversely, for the other 2 networks, maltreatment was associated with significantly increased centrality of the right insular and right precuneus, brain structures both linked to self-awareness. While the insula is involved in interoceptive awareness, that is, processing feelings, including pain, the precuneus is implicated in the recollection of memory, particularly those relating to the perception of an environment. Thus, overall, Teicher et al. Produced evidence that the cortical network organization of maltreated individuals may result in a diminished capacity to regulate impulses and emotions. On the other hand, network structures may heighten the experience of internal emotions and a greater tendency to engage in self-centered mental imagery. Importantly, these findings may provide a potential mechanism for how maltreatment increases risk for psychopathology, such as PTSD. One of the most prominent, reliable findings in childhood maltreatment neuroimaging studies is reduced size or integrity of the corpus callosum. Of note, maltreated males have 2 times greater reduction in corpus callosum area, and this is typically in response to neglect. Whereas for females, the CC is most impacted in those affected by sexual abuse. The CC is a large bundle of around 200 million myelinated nerve fibers connecting the hemispheres of the brain. Thus, CC thinning can result in diminished integrated processing. This is observed in PTSD who show specific activation of their limbic system in the right but not left hemisphere, as well as suppression of left-sided language centers when their traumatic memories are reactivated. Alterations in hemispheric communication can tip the balance and approach avoidance decisions for those with PTSD towards avoidance or anger and aggression. The childhood maltreatment associated structural deficits observed in the adult brain are very consistent, particularly in key limbic, that is amygdala and hippocampus, as well as prefrontal regions, and in the CC. Importantly, these brain regions are critical for decision-making, emotional processing, fear conditioning, and memory, and they're all implicated in the neurobiology of PTSD. The synergies between PTSD and childhood maltreatment are increasingly evident. A recent systematic review of childhood maltreated related PTSD neuroimaging studies demonstrates consistent volumetric reductions and irregularities in all these brain structures over and above those observed in PTSD without childhood maltreatment. Perhaps unsurprisingly, more significant atrophy was associated with earlier and longer in duration abuse and neglect, as well as with greater PTSD severity. The impact of traumatic experiences can be transmitted to the next generation. This is known as transgenerational or intergenerational trauma. There are overlapping issues with childhood maltreatment and intergenerational trauma. PTSD in trauma survivors, including war veterans, has been linked with family dysfunction and symptoms in their children, including lower self-esteem, higher disorder rates and symptoms resembling those of the traumatized parent. The mechanism by which the experience and consequences of trauma, of surviving trauma are passed from one generation to the next are complex and multifactorial. However, the survivor's own coping and distress, rather than simply their exposure to trauma, is crucial to outcomes observed in their offspring. Multiple studies of the children of war survivors, veterans, as well as traumatized refugees shows that they have higher rates of PTSD, anxiety, and depression. For example, among combat veterans, paternal emotional detachment, an aspect of PTSD, has been observed to specifically contribute to offspring distress. So a key question is, when do such parent impacts manifest as something similar to childhood maltreatment? Lerner and Yehuda note the importance of the finding that Holocaust survivors' offspring had biological signatures like those directly traumatized. Furthermore, these biological signatures are observed in offspring of parents with PTSD, rather than in all Holocaust offspring. More specifically, the HPA-axis stress response, typical in PTSD, is found in Holocaust offspring with parental PTSD, regardless of their own PTSD status. Disrupted circadian rhythms, as well as irregularities in the stress hormone cortisol and its receptors via compromised epigenetic regulation, have all been shown to distinguish offspring with parental PTSD. Potential mechanisms for this transmission include in utero exposure to maternal stress hormones, postnatal parental behavior, or direct transmission of trauma-related epigenetic changes from parent to offspring. For example, women pregnant at the time of the World Trade Center attacks on September 11, 2001, who then developed PTSD, had lower cortisol levels than women without PTSD, and so did their babies, particularly those exposed in the third trimester. The fact that children of traumatized parents may show differences in their stress response systems does not necessarily mean that they are damaged, but it does suggest that they may be at heightened risk. Most studies summarized above were cross-sectional. Thus, future research will very much benefit from good longitudinal studies. Through such studies, we will be in a better position to predict the onset of disorder, as well as to determine the best earliest times for interventions in young people at increased risk of PTSD and other disorders due to their exposure to childhood maltreatment and/or intergenerational trauma. Furthermore, well-designed longitudinal studies may be able to tease out the effects of childhood maltreatment versus intergenerational trauma. Neurobiologically focused studies, particularly those with neuroimaging, are key to these endeavors, as it is important that future studies specifically examine the neurobiological differences between susceptible and resilient individuals. This is a key factor in determining specific therapies that may either reverse brain abnormalities or strengthen certain adaptations, as long as there are clinical and/or functional improvements or protections, and that the potential impacts of ongoing intergenerational trauma are mitigated or stopped. Well, would you like to know more? by enrolling in our program, you can discover and learn about many more important topics at the intersection of mental health and neuroscience. Hopefully, this masterclass has demonstrated to you how our postgraduate program is very much incorporating neuroscience research to best understand mental health conditions, and in doing so, helps us all to find new solutions for their prevention and treatment. Thanks for your interest, and now it's time for questions. And as I have a drink and recover my voice, I'll throw over to Chrissy.
Thank you, Dan. That was very informative. We do have a couple of questions that I can answer first, so I'll let you have a little bit of a break. So the first question is about, are the courses, the graduate certificate, are they set, or can we choose other courses to complete for this program? So currently, they are set in those 4 courses, but it is something that we are hoping to work towards in the near future, to be able to have a bit of a decide your adventure type graduate certificate. But currently, they are in that set form at the moment. But if you have any specific questions along those lines, please do feel free to email Dan or I. There is another question I can answer, Dan, and then I've got one for you. So the question is, if I complete the Commonwealth supported graduate diploma, can I then receive RPL for the 8 courses if I enroll in the Masters? Absolutely, yes. So if you complete the graduate certificate, then you want to do the grad dip, then yes, you apply, you get credit, you apply for credit for those courses, you finish off the next 4. Same with the Masters, you can start in the graduate diploma, which, yes, Commonwealth supported places, great idea. When you finish there, you can apply for the Masters, and then if accepted, you can absolutely get RPL for those 8 courses. I will throw one over to you now, Dan. The question is about childhood maltreatment and whether the brain changes are reversible.
Yes, I think I specifically referred to that in the second last slide. So it's possible that some brain abnormalities are reversible, but another point of view is that another approach could be to strengthen those adaptations that Taisha and colleague that we're referring to. I think a big issue here is the chronicity of the impacts, so how long there have been brain changes. And what we do know about what's happening in children is that and that evidence around the specific types of abuse and how that initially impacts sensory systems directly implicated. You get these adaptive modifications in the brain. So if that happens early enough and it's happening on a protracted chronic basis, that those changes may not be reversible in that kind of traditional sense. But there is another view that there are ways that we can strengthen those adaptations for the better. The brain is plastic. Actually, another good angle would be to intervene as early as possible, hence another motivation for identifying these things as early as possible.
Thanks, Dan. So another course-related question. Is a science degree necessary for this postgraduate certificate or diploma, or is recognition of prior research learning taken into account? So, so basically, as I said early on, there are lots of different degrees that will qualify you as that sort of into that postgrad course that we have. Sometimes we recommend that people start in the graduate certificate if there's not a strong science background, but we do look at all of the applications and do take into consideration any other workplace experience and things like that, like you say, prior research and learning as well. So hope that answers that question. There is still time to apply for semester 1. That was another question. So yes, absolutely. O week is next week. Semester 1 starts on the 26th of February. I would recommend that if you are thinking of applying, that you would do it sooner rather than later, so you're not playing catch up of the content and trying to kind of get things together in the first couple of weeks. Otherwise, the next intake is semester 2, which generally starts around the end of July, but you can apply for semester 2 as well. So you can put your application in and specify semester 2 if you want to just wait until then. So both options are definitely open. Another course related question. So Dan, you happy for me to keep going?
Yes.
So would we recommend completing a mental health certification as a beginning prior to postgrad? I think that would depend on what your background is. So that might be a question that we could better answer if we've got a little bit more context of your background. So I'm happy to have a conversation via email about that in more detail. Is there a maximum time to complete the courses? I'm not sure. I think it used to be 10 years for a degree, but you can do one course per semester. You can have a semester off and come back and do another course or another couple of semesters. So yeah, it's really quite flexible in that sense. You can take a leave of absence, absolutely, if you need to have some time off. But that would probably be a better question for perhaps student admissions or student services, just to clarify what the maximum time is to complete a course, because I'm not 100% sure on that one. Another question, so is the Masters Commonwealth supported? So currently, no. The best financial option would be to apply for the grad cert or grad dip, well, the grad dip now, and then upgrade to the Masters later. So yeah, hopefully that's something we can look to getting, but currently it's just the grad cert and grad dip that are Commonwealth supported. So then, yeah, if you started in the grad dip, did those with your Commonwealth supported place, then you would only be paying the full fee for the final few Masters courses. So I hope that makes sense. Dan, a question for you. Has there been any research on how people from different countries are affected by childhood maltreatment, and are the impacts the same? Great question.
Yes. Well, we do address this in the modules in more detail. Just thinking through. Well, in terms of cultural differences, I guess is one way to say it. We do specifically look at the difference in Aboriginal and Torres Strait Islander communities, First Nation populations in Australia. There is some evidence that different types of childhood maltreatment, early life stress have different impacts, going forward. The particularly interesting links between early life stress, childhood maltreatment and stress and trauma, and cognitive decline. So some really long-term studies, and there's some very good research in Australia looking at Aboriginal and Torres Strait Islander communities in that regard, and that is covered in our module. In terms of neurobiologically informed studies, I'd say there isn't enough across countries and across cultures because of issues around access to MRI and scanning facilities. So unfortunately, most of the data that we have is from Western countries. In the intergenerational trauma space and in that module, there's some content that we've looked at around the concept of collective trauma, which is an interesting concept as well. So touched on some of that research looking at Holocaust survivors and intergenerational trauma passed on to offspring. But there's some other content that we address in the module looking at collective trauma experienced by Holocaust survivors, but also survivors of Rwanda, the Rwanda genocide. And there's another one that escapes me right now, but there is research that have looked at that across countries, across cultures. I hope that answers the question.
Thanks, Dan. So we've got a few more questions about the courses. So in WA, working full time, would the time difference be an issue for live lectures? So in terms of lectures, the content that you would receive in a lecture are all within your module, which you can look at any time. So you wouldn't be missing any of that kind of lecture type material. We have various different times for Zoom drop-ins when we have our Zoom drop-ins. And so these are when we discuss the content, talk about assessments and things like that. We generally have two options of times at the moment. We have one Brisbane time, middle of the day, and Brisbane time in the evening. These sessions are generally recorded so that we can then post those afterwards for people to watch if they miss them. But yeah, we do have students from all over Australia, so we do try and offer different time slots as well. So hopefully one of those fits. There's a question about how many assessments there are generally in the unit. So every unit in the Grad Cert and Grad Dip has 3 assessments. So I can let you know that generally the first assessment falls between sort of week 4 and 6 of the semester. The second assessment generally around weeks 9 to 11, and then the final semester is, the final assessment is normally after the teaching period is finished, so around what would normally be the centrally scheduled exam period, for those of you who know the kind of course semester setup. So yeah, generally 3. So there's a question about the assessment structure, what they look like, what type of things that we do. So we have, I'll give you an example. So 701, this semester, we have 3 assessments. The first one are information pamphlets, so more about science communication to a broad audience, where you have to present 2 different disorders to the general population, including the neurobiology of these disorders. So they're more kind of, science communication and information for the general population. The second assessment for 701 is a perspective piece. So this is where you get to have a look at the evidence base more deeply, present a bit of an argument towards a certain perspective, and you can choose to focus on a particular disorder, and that one is about the issues with diagnostic categorization. And then the final assessment for 701 is a recorded PowerPoint presentation. So you don't have to present to a real audience, you're just recording it yourself in PowerPoint, and that is a general pop audience, again, talking about a novel therapy. So that's just an example of one. We also have some online quizzes. We have more literature review style. We have 3-minute thesis type presentations. We have, but there are all of those, the presentations are recorded in your own time. You never have to do it in front of anyone or on the spot in front of me via Zoom or anything like that. And yeah, the rest are generally different writing styles. One of my favorite assignments is a frontispiece on minds paper in the Youth Mental Health and Neurobiology course, which is where you get to write about a particular disorder that's prevalent in youth for a young population. So you get to really kind of delve into describing these things in a way that youth can understand. So a wide variety of assessments, no final exams though. Okay, lots of questions. Many occupations like the medical system known for causing CPST level. Okay, so this is a question for you, Dan. Many occupations like the medical system are known for causing CPTS, so childhood post-traumatic stress, let alone intergenerational and physical traumas. So do we cover occupations causing this and how they affect the family and the community? So do you want to expand on that a little bit in terms of the content?
I'll try. So that CPTS, I'm assuming, is chronic post-traumatic stress.
Oh, chronic.
I don't think we have content that looks at how medical systems cause or impact that. It's not something I'm familiar with. But I guess this touches on a broader concept. The idea here is that, in our courses, in our program, we really tried to work on the research-informed tools, if you like, to help address and answer these questions. So if that was a line of inquiry that this person who's asking the question is interested in, I'd like to think that the structure and the format of the course and the way that we look at critical analysis and critical synthesis of current research and the pros and cons and the for and against for different types of arguments could help, look at that question.
Yeah, and I guess on that note, in the particular course, we have an assessment item that allows you to choose a topic to focus on, and one of those topics can be, the impacts of intergenerational trauma and some of the different perspectives surrounding that. So there is an opportunity to, I guess, unpack some of those things, like Dan says, from a critical perspective and looking at the literature and seeing what it says. So hopefully that answers it. Okay, so is the graduate diploma course 2 units per semester part-time? So yeah, with the graduate diploma, well, with any of the courses, you can do 1 or 2 courses per semester, which counts as part-time, or 3 or 4 is generally considered full-time. But obviously, to complete the grad dip in a year, it would be 4 per semester. But yeah, you can 100% do the graduate diploma, 2 courses per semester, part-time, meaning you can spread it out over 2 years. And to be honest, that's what a lot of our students do, the 1 or 2 courses, especially if they're working full-time. So what might be the benefit to studying these courses as opposed to psychology? That's a great question. Having studied psychology myself, and now, in the mental health and neuroscience field, obviously they're very closely related. And Dan, you can chime in with any of your thoughts on this too, because you've done a similar pathway. I would say from my years of studying psychology, that's a lot of theories, And I guess for me, it was the lack of the applied aspect, unless you wanted to go and do clinical psychology. So, if you want to do that if you want to be a clinician, then obviously that's the appropriate pathway to get qualified as a clinical psychologist or professional psychologist. So that would be one thing that should influence your decision. Whereas our course is very applied in terms of how we can use this knowledge, how we can use the neuroscience knowledge to better understand mental health, to improve our current practice in whatever field that may be, and our current understanding. But yeah, if it's an accredited pathway you want at this point, then psychology would be that option. Anything to add there, Dan?
Oh, just that, I did an undergraduate degree majoring in psychology. I've been involved with psychology schools, disciplines around the country. They can differ in their makeup, and therefore the themes and content that they cover in undergraduate programs. My point being, some schools might be more into social psychology or organizational behavior, or abnormal psychology or cognition and so on. So that's one thing. You should look at the makeup of the school. But one thing that we do that many disciplines in psychology and therefore the programs don't really cover are things like classification systems specifically involved with mental disorders. So we probably have a little bit more psychiatry, if you like, that mental disorder specific classification systems, as I mentioned, and also new ways that we're understanding these and how they interrelate. And of course, then there's the neuroscience and neurobiology, which may not be covered in similar detail in psychology programs.
Yeah, we definitely delve a lot deeper into the neuroscience than what you would get in a typical biopsychology or a physiological psychology course. So yeah. So just another question, sorry, just double checking if treatment of these conditions are strongly emphasized in this course, as well as diagnostics and brain changes involved. Absolutely. Yeah, we definitely cover treatments. We talk about, current treatments, the pros and cons of current treatments, but also we're looking at a lot of the novel treatments that are becoming more and more researched in this area. So things like ketamine and psychedelics, psilocybin, MDMA getting a lot of airtime at the moment, but also things like TMS, neurofeedback, EMDR, flash technique, particularly for things like stress-related disorders. So yeah, we definitely cover treatment as well, the neuroscience behind a lot of these treatments as well. I think we've got one final question. Oh no, there's a few more. I needed to scroll down. My bad. A specific order to follow. I think no, not currently. You can sort of pick and choose. I would say if you're starting this semester that I would recommend starting in 701, as this is sort of, does give you a good taster of all the content across the other 8 courses. But yeah, technically there's no specified pathway or order to complete them. Is there a time frame completing 4 units and 8 units? Yep. So as I said before, you can take your time and go slowly through the courses. So I think I answered that one previously. Okay, so one for you, Dan. The information Dan shared seems to be about the science that is behind trauma-informed care. Is this correct? And if so, how would this enhance the practice of a professional mental health clinician?
Yeah, I'll try to answer that as best I can. So, yes, somewhat is the simple answer. But a lot of, well, trauma-informed care is really an approach where the focus is on through therapy on the acknowledgement of trauma or trauma experience by the person, and then unpacking that and working with them on that front. And that could be entirely psychological. I guess what I would say that could enhance practice would be perhaps other content and other research that we look at in terms of the neurobiology, and that informs that. So often we find that it's helpful to talk to people about mental health problems and their experiences from a brain health point of view as well. So mental health equals brain health is a key philosophy we have. So I'd like to think that the science behind trauma-informed care, there could be another step or two whereby the neurobiological science that we understand about trauma could be implemented in that practice. So perhaps that would be a good way for clinicians to talk about if they're focusing on something like hypervigilance or hyperarousal. They may explain that from a neurobiological brain point of view as well.
Cool, thanks, Sam. Okay, I think I have reached the final question. So it's basically around the eligibility to work as a mental health neuroscience-based therapist. Is the course recognised by associations or Medicare? So at the moment, the course isn't currently accredited. It's something that we would like to look to in the future. That process can take a few years to be accredited, but it is something that is on our radar. So at the moment, I guess just to reiterate that our students are often working in this space and it's enhancing their practice, or they're looking at moving into more wellbeing, mental health and wellbeing focused roles, and just using it to advance their careers or move into a different area. But in terms of accreditation at the moment, we don't have that. But as I said, in the future, we will look into this. Okay, what's the next step to enrollment? So I guess the first step is to apply. Give as much information as you can about your qualifications, your work experience, etc., in your application. And then if you receive an offer, then you will be informed by USC how to enroll in the courses, and therefore you jump on and enroll in however many courses you want for this first semester. Okay, this is definitely the last one. Is it possible to do any of the courses in person, i.e. attend the classes? So at the moment it is fully online, which is great because it means you can do this in your own time. So there are no in-person classes at the moment, but as I said, we do have lots of opportunity to connect via Zoom at this point in time. I'd like to say
that I think we missed.
Oh, really?
I can't resist. I mean, there was a question about is epigenetics covered as new knowledge or prerequisites knowledge? Did we
Oh,
cover
okay.
that one?
No, I missed that one,
Quickly,
sorry.
yes, we do it in one of those modules I mentioned before. We do touch on epigenetics, and then there's an extension resource and an additional. So we talk about, in general terms, methylation and what happens with in this epigenetic process. And there's also a really interesting TED talk that we've included where the researcher there explains how epigenetics fits in the nature versus nurture argument. So yeah, great question.
Okay, Dan, I think you can wrap it up now.
Oh, I'm doing the wrapping up. Okay, I will.
Yeah.
Thank you. Well, that concludes our third masterclass and Q&A session. Thank you all for your attendance and your interest. We really do appreciate your time and especially the questions. I hope that we've addressed them all. And as mentioned, we will try to follow them up in some way. As Chrissy mentioned, you'll get access to a taster module, a mega module summarizing all of our content. You can rewatch this webinar if you like as well and check out the other ones. And if you have any other follow-up questions, please do get in touch. Semester one starts in a week and a half or thereabouts time. We're still accepting applications, so very happy to receive them. And I think that's all I should say, except to say thank you all again. Thanks, Chrissy and the UniSC team who helped us make these webinars possible. And I hope you all have a great rest of your day. Thank you.
Thanks, Dan.